Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and today I'm going to start a series of lectures on acute metabolic complications of diabetes. Now, it will be three parts. In the first part, we will be discussing pathophysiology of diabetic ketoacidosis. In the second lecture, we will discuss the treatment of diabetic ketoacidosis. And in the third lecture, we will be briefly discussing other two relatively less common types of metabolic complications in diabetes called hyperosmolar hyperglycemic state and also diabetic lactic acidosis. So let's now discuss the pathophysiology of diabetic ketoacidosis. So this is a condition, it's an acute metabolic complication of type 1, mostly type 1, because the cause of this syndrome is severe deficiency of insulin or absence of insulin. That is the feature of type 1 diabetes, but occasionally in type 2 also, because in type 2 diabetes, when there is stress, there could be increase in counter-regulatory hormones, and that could actually also cause DKA, especially those patients of type 2 diabetes who are on SGLT2 inhibitors. It is caused by insulin deficiency. That is the important cause, because you can't develop DKA if you have sufficient insulin in the body. And it is characterized by severe hyperglycemia. Obviously, if there is no insulin, glucose level will go up, and I think in most patients with DKA at the time of presentation, blood sugar is 350, 400, something like that. Of course, there is a condition called euglycemic DKA, but that is an exception. Mostly you would expect patient to present with sugar of 350 plus. And that hyperglycemia results in osmotic diuresis, and patient will develop dehydration. And according to some estimate, most patients at the time of presentation, they have at least 6 or 7 liters of fluid deficiency. So that means this is another important component. You would expect some clinical features of dehydration. Then, because insulin is not there, because glucose is not used as fuel, and ketone, the fatty acids, are used as an alternative fuel, which results in the formation of ketone bodies, and that results in ketonemia, and then ketones are excreted in the urine, and that results in ketonuria. So these are the important component of this syndrome. Finally, because these are acids, and when they accumulate in the body, kidneys do try to correct that acidosis, but once there is an overwhelming increase in ketones, there is metabolic acidosis with wide anion gap. I will discuss these components in more detail, but as part of definition, a clinical syndrome where patient presents with altered state of consciousness with dehydration because of insulin deficiency, and there is ketonuria, ketonemia, and metabolic acidosis. Index of suspicion of DKA should be high. Any young person presenting with unexplained altered state of consciousness, I think you must include DKA in the differential diagnosis. Precipitating factors. First of all, it could be the first presentation. This may be particularly difficult to pick up for youngsters, because patient may not have known diabetes. Maybe only for the last couple of days, patient developed severe hyperglycemia, and then it progressed to the state of DKA. So it could very well be the first presentation of type 1 diabetes. But mostly it occurs when somebody is a known case of diabetes and he was on insulin, the patient was on insulin, but patient discontinued. There are so many reasons why patient would discontinue. Non-availability of insulin, or patient was stuck in some situation where he could not have access to the insulin, or somebody in our country, somebody just misguided him and told him that insulin is not necessary, it should be discontinued. So due to one of the reasons, patient discontinued insulin, that could result in DKA. Another situation is that patient did not discontinue, but there was an indication to increase the dosage of insulin. The patient was stable on insulin, but because of some trauma or some operation or some stress, insulin the requirement increased, but patient did not increase the dosage of insulin. So that would also result in relative insulin deficiency. Then stress, in some stresses, our counter-regulatory hormone levels can go up to 10 times. That of course would counteract the effect of insulin and can precipitate DKA. The pathogenesis, very, very important. I think DKA or diabetic ketoacidosis is one of those metabolic situations where we understand the actual biochemical abnormalities quite well. Now, why it is important to understand? Because that translates into better interpretation of lab results and also the better treatment. With the good understanding of this condition, it is definitely much likely that you will be able to handle this condition much better. Now, there is of course very fundamental to the pathogenesis of DKA is critical insulin deficiency. And then there is also glucagon excess. Both these hormones, deficiency of insulin and excess of glucagon, they collectively actually generate certain abnormal mechanisms which ultimately results in the classical syndrome of DKA. And this is also called double trouble hypothesis. When there is insulin deficiency, beta cells actually regulate alpha cells also. So when there is deficiency of insulin, they are unable to inhibit alpha cell, because then uninhibited alpha cell, they secrete a large amount of glucagon, which is actually not necessary when there is already too much glucose. So both these hormone deficiencies will result in reduced utilization and increased production of both glucose and ketones. I think if you understand this part, both the hormones will cause reduced utilization of both glucose and ketones, and both the hormone will result in increased production of both glucose and ketone. So obviously this will result in severe hyperglycemia and ketosis. Hyperglycemia, since it is osmotically active substance, it will result in osmotic diuresis. Typically, patient with DKA, they would give you the history of diuresis, polydipsia, polyuria for preceding many days. Because these symptoms are not very painful, patient had ignored them, and only when the patient developed severe dehydration, only patient was brought to the hospital. So osmotic diuresis will result in dehydration, and of course there will be depletion of sodium and potassium. Both sodium and potassium are depleted from the body. But since sodium is depleted along with the water, so in the majority of the patient at the time of presentation, you would expect sodium to be normal, although total body sodium is depleted. Similarly, potassium is excreted into the urine. Body will be deficient in potassium, but mostly as potassium is lost into the urine, more potassium comes out of the cells. So when you measure serum potassium, mostly at the time of presentation, potassium would be normal. So when we measure electrolyte in a typical patient of DKA, you would expect sodium potassium to be within the normal limits. Occasionally it may be high or low, but mostly it will be within normal limits. And reason is that potassium comes out of the cells to compensate for the potassium loss. Then ketones, it will result in, because ketones are acids, when they accumulate in the blood, they will cause metabolic acidosis with wide anion gap. I will explain to you in more detail what is wide anion gap type of metabolic acidosis. So this slide sum up basic concept: insulin deficiency, glucagon excess, both of them lead to reduced utilization of glucose and reduced utilization of ketones, and increased production of glucose, increased production of ketones. Both of them cause hyperglycemia, ketosis. Hyperglycemia causes osmotic diuresis, dehydration, and sodium and potassium depletion, and accumulation of ketones would cause metabolic acidosis and wide anion gap. And when you measure serum ketone levels, it will be high. And since these ketones are excreted in the urine, you would have ketonuria also. Clinical features, first important feature is polyuria and polydipsia. Patient has progressive polyuria for the last maybe 6-7 days, but probably did not realize that there is something serious going on, and patient just ignored it, and as a reflex, patient would feel thirsty, would take a lot of water to compensate for the volume loss, but water intake may not be adequate, may not be sufficient to compensate for the volume loss. So patient would develop dehydration. Most patients at the time of presentation, they are deficient by about 7 or more liters. There may be altered consciousness, the number of factors which would affect one's consciousness: hyperglycemia, then dehydration, hypotension, and accumulation of ketones which have adverse effect on the brain. So most patient would be either drowsy or stuporous. Very rarely patient may be in a state of coma, but I think if a diabetic patient presents in complete grade 4 coma, it is more likely that the patient has hypoglycemia. In DKA, in all those conditions where there is hyperglycemia, patient has altered state of consciousness, but not to the extent of coma. Patient is usually stuporous or drowsy or agitated. Then patient may be hyperventilating. Now this is, I think the youngsters need to understand the difference between dyspnea and hyperventilation. Dyspnea is a feeling of not being able to breathe properly and feeling of shortness of breath. Whereas hyperventilation is a phenomenon where patient takes deep and rapid breaths. Patient may not feel dyspneic, and in fact in DKA, dyspnea is hardly ever a presenting symptom. But when you examine the patient, you will see that patient is hyperventilating. That means the respiratory rate is increased and the depth of every breath is also increased. And this is called Kussmaul's breathing, because this is the first time described by a scientist called Kussmaul. And this is because of acidosis. Metabolic acidosis will stimulate our respiratory center to cause hyperventilation. So this is why we have this phenomenon in DKA. Then there may be acetone smell. You know, there are 3 types of ketone bodies which are formed in DKA. One of them is acetone. Acetone is volatile and can be exhaled through breath. So an experienced physician can immediately tell in a proper person who is just drowsy and has got this acetone smell, you can tell that this patient has got diabetic ketoacidosis. Differential diagnosis is wide. Actually, I have given you a very short list. Any condition where altered sensorium could come in the differential diagnosis. Some common examples: uremia, meningitis, encephalitis, cerebrovascular accidents, various types of poisonings, head injury, and alcoholic ketoacidosis, and even alcoholic overdosing. So I think all these conditions can cause clinical picture very similar to DKA. But there are, of course, many other conditions which can be considered in the differential diagnosis. How do we make a diagnosis? It's easy actually. First of all, typical presentation. The typical presentation is a young person who is already a known diabetic on insulin and who has stopped taking insulin recently, or had some stress but did not increase insulin, or patient did not know that he or she has diabetes, but there has been progressive polyuria, polydipsia, weight loss, dehydration, and maybe acetone smell. You could actually suspect quite accurately that this is a case of diabetic ketoacidosis. So presentation is quite typical. Then when you examine the patient, of course you take vitals, you take a history usually from the attendant, and you examine the patient, and immediately you check his sugar. These days it is very easy to check one's sugar on the bedside, so you could ask the nurse or your colleague to check the sugar, and if the sugar is high, that would further confirm the diagnosis of DKA. And if you do not have the facility of sugar testing, then maybe you can test the urine also. Of course, these days in almost all healthcare facilities, there is the facility for glucose testing with the strip is available, and it just takes a few minutes to get the result. Then I think ideally you should check ketones. Traditionally, we used to check ketone urea. A normal person should not excrete ketones in the urine. Although there are several conditions where there could be ketones in the urine and patient may not have DKA. But in this perspective, in this type of patient, if ketones are detectable in the urine, that would suggest diagnosis of DKA. These days, we are preferring the ketone estimation in the blood because this gives us a more accurate reading, and you don't have to wait for the patient to pass urine, and plus you can monitor it. And in fact, many glucose meter and the small machine which tests the sugar, many new glucometer, they also have the additional facility of checking ketones. So with the same instrument, by using another step, you could check glucose as well as ketone. So serum ketone level would be increased. Arterial blood gases, this is extremely important. ABG is an abbreviation of arterial blood gases. Now, we always try to get arterial blood gases, but you have to puncture an artery. You need to have special training for that. And many times, the emergency doctor may not be able to puncture an artery. So I think venous blood gases are also acceptable. But I strongly recommend that in the first evaluation, you should go for arterial blood gases, but subsequently we can monitor one's blood gas on the venous sample, because venous sample is much easier to take and less traumatic for the patient and less chances of complication. What do you expect on the arterial blood gases? You expect metabolic acidosis. Now this downward arrow indicates that all these three parameters which are measured in the arterial blood gas test, pH and bicarb and CO2, all three will be low. pH would be low because that is what acidosis says. In all cases of acidosis, pH has to be low. Bicarb will also be low because this is kidney's compensation trying to correct the acidosis, and because of acidosis, patient is hyperventilating, and because of hyperventilation, patient is washing out his or her carbon dioxide, then you do have low carbon dioxide. So all three parameters are measured in arterial blood gases. If three are present, you have made a diagnosis of metabolic acidosis, and along with hyperglycemia, the diagnosis of DKA is extremely likely. The second thing is you measure serum electrolytes. In serum electrolytes, you measure sodium, potassium, bicarb, and chloride. Now, there would be widened anion gap. Now, I'm going to explain what is anion gap. Now, this is the normal equation. You know, we have positively charged ions in the body, mostly sodium and potassium. There are other positively charged ions also, but mostly we just count sodium and potassium. In fact, in some of the question, even potassium is not counted, just the sodium is counted. And we have negatively charged ions, main negatively charged ions, the cations, which we measure, they are bicarb and chloride. So normally in a normal healthy person, positively charged ions should equal the negatively charged ions. But in the negatively charged ions, we also have some negatively charged ions which we normally do not measure in routine blood gas or routine serum electrolytes, like sulfates, carbonates, phosphates, urates, acetones, acetoacetic acid, lactic acid. These things we do not measure in routine electrolytes. So the concept is, if you have something accumulating here, for example, this ketone bodies, they would be included here. Normally, we do not measure ketone bodies when we measure electrolytes. But if ketones are accumulated in the body, it will increase this component, and as a compensation, body will excrete potassium to equalize the equation. So what you will notice on routine electrolytes is that the gap between sum of sodium and potassium and sum of bicarbonate chloride is increased. So this increased gap actually reflects that some acid has accumulated here. So if you have a case of acidosis with widened anion gap, that means something here has increased. Then of course, depending upon the clinical condition, you can suspect what can be that something. In this scenario, that something would be ketone bodies. But if somebody has typical presentation of renal failure, then of course we have other things measured here. Then aspirin poisoning, other poisoning. So depending upon what you suspect, then specific tests can be done. So I think this was a basic concept of acidosis, metabolic acidosis with wide anion gap. So if you have this scenario, typical presentation with hyperglycemia, ketonemia, and ketonuria, arterial blood gases showing reduced pH, reduced bicarb, and reduced carbon dioxide, and anion gap is widened, I think the diagnosis of diabetic ketoacidosis is definite. Now, major abnormalities, and I'm going to give you some more explanation to what are the major abnormalities and how do they happen. First is hyperglycemia. Now, I'm actually identifying major biochemical abnormalities in DKA so that we can address them when we treat them. So first, of course, we have hyperglycemia, and hyperglycemia is due to deficiency of insulin. Then there is dehydration. I have already told you that most patients with type 1 diabetes at the time of presentation with DKA, they have fluid deficiency about 6-7 liters. So that has to be replaced. Then patient would have electrolyte depletion. I made a point that sodium and potassium may be normal, maybe within normal range when we measure their concentration, but their total body sodium and total body potassium are both depleted. So we have to replace sodium with normal saline, and we have to replace potassium as potassium chloride, extremely important. And then we have acidosis. Mostly we do not treat acidosis because once insulin is replaced, once fluids are replaced, then ketosis actually reverses back and acidosis is corrected on its own. But in some cases, we have to treat acidosis also. Now, first, these three things, I'm going to talk in some more detail, these three things. Causes and consequences of hyperglycemia. Cause, of course, is insulin deficiency or insulin absence. along with increase in counter-regulatory hormone, and main hormone we're talking about here is glucagon. But cortisol, catecholamine, growth hormone, they're all increased. So both together they cause severe hyperglycemia. And because of this, glucose disposal in the tissues is reduced, because most insulin dependent tissues, they need insulin for glucose to enter the cells. For example, the muscle cell, the fat cells, the glucose cannot enter. So if glucose cannot enter the cells, it cannot be used, so it will accumulate in the plasma. And there is also, because of the excess of these counter regulatory hormone, there is increased hepatic glucose production. Now this is very ironic. Somebody already has too much glucose, but because of the increase in counter-regulatory hormone, body perceives as if glucose is not there, because glucose is not available to the cells. So from the cells, body perceives as if there is deficiency of glucose, and by activating counter-regulatory hormone, more and more glucose is produced. So less glucose is used and more is produced, that results in severe hyperglycemia. Now once there is severe hyperglycemia, once our plasma glucose level exceeds 180, it starts excreting in the urine, and of course it will take with glucose will take some water with it, and there will be water diuresis. So that will result in dehydration. And also, because this process goes on and on, it would lead to depletion of sodium and potassium. Patient may be drinking just water, because this osmotic diuresis, dehydration, will stimulate thirst. Patient may be just drinking simple water. If patient is taking simple water, then it is more likely that patient would have deficiency of sodium potassium. But if somebody is drinking some drinks with some salt or some potassium, then the deficiency of sodium and potassium is less severe. Similarly, now if somebody is drinking sweet drinks, of course, if patient is not a known diabetic, if this is the first presentation, if he's feeling thirsty, if patient is feeling thirsty, patient may be drinking sweet drinks. That will further increase hyperglycemia. So this is the causes and consequences of hyperglycemia in DKA. Now let's take this one, acidosis. Uh, acidosis, acidosis, the causes and consequences of acidosis. Again, same two mechanism: a reduction in insulin and increase in counter-regulatory hormone. There is, because glucose is not available for energy production, because glucose cannot be utilized without insulin. So glucose is not available. Body has a backup mechanism of using fats, and that is through beta oxidation of fatty acids. So these ketone bodies and other fatty acids, they are oxidized to produce the energy. So as a result, ketone bodies are increased. So these ketones are acetone, which is mostly exhaled, and acetoacetic acid, which is excreted, and beta hydroxybutyrate or beta hydroxybutyric acid. These are three ketone bodies. We call them ketone bodies. They are actually acids, and they cause acidosis. And once ketones accumulate, they will result in hyperketonemia, and also this ketone will be excreted and will cause ketonuria. So, and once and body will try, the kidneys will try to compensate for this acidosis by excreting bicarb. So, because bicarbs are excreted and bicarbs are also used to neutralize the acid, then bicarb level is reduced. And because, as I explained in one of the earlier slides, because the acid from anion gap region is increased, so there would be widened anion gap. Thank you very much. So this was a relatively short presentation, was actually 30 minutes, but I was focusing on pathogenesis or the pathophysiology of the key abnormalities in DKA. To sum up, the critical problem is insulin deficiency or insulin absence. And critical biochemical abnormalities are hyperglycemia, ketonemia, ketonuria, dehydration, sodium depletion, potassium depletion, and all these need to be corrected, and that we will discuss in our next lecture, which will focus on the management of DKA. So I request you to please join me in my next lecture. Till that time, goodbye and look after yourself. This is Professor Aziz-ur-Rehman from Medurstand.